Good morning. My name is Jens Chapman. I'm the chairman of the Department of Orthopedics, Surgery, and Sports Medicine. And next to me is Dr. Mackinson.
Good morning, everyone. Burkhard Mackinson, acting chair, anesthesiology and pain medicine.
And in absentiam for Dr. Pellegrini, who unfortunately couldn't be here, it is our distinct pleasure to welcome all of you from the departments of anesthesia and pain medicine, departments of general surgery and its divisions, and the Department of Orthopedic Surgery and Sports Medicine to today's combined Grand Rounds. It's a special occasion that the three departments come together for Grand Rounds, and today is one of those very special occasions as we have a featured guest speaker. So it's a particular pleasure to introduce to you Dr. Gurman, and let me just introduce a couple of background information pieces from him. As you probably gathered, Dr. Gurman is a hand surgeon, a practicing orthopedic surgeon. I want to take this occasion to thank Dr. Vetter to have invited him here. Dr. Gurman's background is from upstate New York, and he attended undergraduate and graduate schools in Syracuse and the University of Rochester. He did his residency training and internship at Montefiore Hospital in the Bronx. I should say Bronx. We'll have Burkhard do that in a second also. And he attended the Kellogg School and the Kennedy School for Advanced Management and Leadership Training. He is from early on been active in political medicine, which is a particularly important and frequently overlooked aspect of our representation. Dr. Gurman has been active in the Pennsylvania Medical Society and the American Medical Association, and the latter organization he's been a member of since 1976 as a student member, and he's risen up the ranks in both organizations. He's now the Speaker of the House of Delegates of the AMA and is in the presidential line. Dr. Gurman is an outstanding speaker who will talk to us about the implications of the Affordable Health Care Act and our lives as physicians and our need for political representation, as a lot of healthcare reforms are underway, pressuring us to show value in our healthcare and hopefully also impacting positively healthcare delivery. Burkhard, would you want to say anything else?
Well, just having come back from Philadelphia at the end of last week, where the AAMC and similar meetings were held, it is clear that we are really in a new era of medicine where we have to really look for how we can make ourselves as physicians even more valuable to the system and irreplaceable in a large degree as we move forward to forming an ACO, as we move forward to the Affordable Care Act. So really to deal with issues around physician satisfaction as a start, but then also looking into making ourselves more valuable, I think is really critical in this time. So I'm really happy to see all of you and welcome you to start your lecture. Thank you.
Thank you. Good morning. I'm absolutely delighted to be here. I have a lot to talk to you about. So I'm going to go through fairly quickly. There will be time for questions at the end, I hope, and I will hang around a little bit as long as anybody cares to talk. I have found that when I come to speak to groups and I ask them, what is the AMA? I get a lot of quizzical looks. So the first thing I'm going to do is tell you what the AMA is, how we do our business, and what the ramification of that is for when you read in the paper that the AMA supports this, the AMA doesn't support that. So I'll go a little bit through structure and function of the AMA, talk a little bit about our healthcare system and the reform efforts that are underway. I'm going to talk about some advocacy issues, including prescription drug diversion and opioid overdose. I have a full talk on that. I'm going to abbreviate that very much, but it is an advocacy issue that we need to be spending some time thinking about because the folks in Washington are thinking about it as well, and if we don't solve it, they will make an attempt to, and you all know Ronald Reagan's famous quote about the most dangerous phrase in the English language, I'm from the government, I'm here to help. So we're going to try to address that a little bit. I'm going to talk about the AMA strategic plan, which is a broad brush attempt to address three areas: improving health outcomes, physician satisfaction, and a transformation of undergraduate medical education. And then we'll talk about whatever you care to talk about. So the AMA is a lot of different things. We are the largest publisher of medical literature in the world with the JAMA Network. It used to be archives of lots of different things. Now it's all called the JAMA Network. We're a data mining company. We maintain the AMA master file, which is a list of physicians in this country and various informations about them. We have the physicians data reporting activity as well. We are an insurance agency. We independently, meaning at arm's length, are also the publishers of CPT codes, which are the numbers, as you all know, by which we communicate with insurers and other things. We also have the House of Delegates, which I'll talk about a little bit more, and we do advocacy on behalf of physicians and patients. The AMA was founded in 1847 by Dr. Nathan Davis in upstate New York because he looked around and he saw poor quality, lots of literally snake oil salesmen at that time. There was no standardization of medical education. There was, at that time in 1847, no public health department in any city anywhere in the country. So Dr. Davis was instrumental in getting that going as well, and also started talking about medical ethics. Just a few milestones. We formed the Joint Commission in 1951, and we called for seatbelts in cars. We defined alcoholism as a disease. We adopt a report on the harmful effects of tobacco in the early 60s, and you can read the slides. But what I want to point out to you is in 1997, we established the National Patient Safety Foundation, some 7 or 8 years before it became in vogue to start talking about patient safety and quality issues in that line. So who is the AMA? This is a bit of an old slide. We're now about 245,000 physicians. We have about 900 staff in Chicago. We have a little bit over 100 in Washington, D.C. We're the largest health advocacy shop in D.C. And we serve as a resource for lots of other groups, the American College of Surgeons, the American Academy of Orthopaedic Surgeons, their shops, and the anesthesia group as well. They work very closely hand in hand with our group and very frequently rely on the research that's done by the AMA. There is a very good partnership in the Federation in advocacy efforts, among others. So the AMA is playing a pivotal role in the process of unifying physicians, and through our House of Delegates, the AMA represents 185 state, specialty, and subspecialty societies. We've even got 2 hand societies. We've got a left-hand society and a right-hand society. It's the preeminent voice for most of America's physicians. And I talked about membership in a previous slide, but the thing to remember is that the policy, which is made by the House of Delegates, is made by a representative body that represents over 95% of the practicing physicians in this country. I am represented in the House of Delegates by 5 entities: Pennsylvania, Orthopaedics, 2 hand societies, American College of Surgeons. I figured out if you were a gay woman of color who was educated abroad and was in a medical subspecialty, you'd have 11. So you are represented whether you are a member or not. I'm hoping that by the end of my talk you will be so overwhelmed that you will be begging me to give you an application for membership. Great, we'll take care of that. But whether you do or you don't, and I hope that you do, because it is your profession and your organization, the point is that the AMA is representative of you. The House of Delegates has got 541 delegates, and then there are alternates and staff. There are specialties, as you can see listed. The military is there. I highlighted that because I used these slides yesterday for the AMSIS meeting. And the policy is made by the House of Delegates. The AMA can be thought, we think of it as the AMA equation, which has the House of Delegates, which is the voice of physicians through their organizations. We have direct membership, and people have access into the policy-making process of the House of Delegates. If you are a member, you can log on to our online forums and give testimony regarding things that are before us. We have practice tools and research and education and all sorts of different things, and advocacy. By the way, there's lots of seats down front if anybody in the back wants to do that. All right, so let's talk about building a new healthcare system for a little bit. At the AMA, we saw the Affordable Care Act as the only available response to gross inequity and access to quality health care soaring medical costs, and a desire to better serve this country's citizens. Remember, people who don't have health insurance live sicker and die younger. Those data are incontrovertible, and pretty much everybody across the political spectrum accepts that. The United States of America has been trying since Teddy Roosevelt to address this problem in some sort of national program. And I won't go through the history of all of it, but the Affordable Care Act was just the latest in a series of efforts. And many of you remember the last shot, which was the Clinton health plan and how that worked. So the AMA has been supportive of the Affordable Care Act. It is far from perfect. There are a lot of things that we still need to change. I had an interesting discussion before with one of your residents about the inside baseball politics of how this law came about. Be happy to talk to you about it later if you're interested. But the fact is, it is the law of the land. It is an imperfect law, born of an imperfect process, and we are still working to make it better. One of the things that's in the law is Medicaid expansion. Now, the original bill, in one of its early iterations, called for a mandatory acceptance of federal dollars, and some of that was overturned by the Supreme Court. The rest of the law was left standing. But this is what's going on across the country in states deciding to accept Medicaid expansion. According to the Supreme Court, the state doesn't have to. The federal government pays 100% of the costs for 3 years and 90% of the costs thereafter. And what it does is it expands Medicaid eligibility to people who are within 138% of the federal poverty limit. That is, I think, $29,000 for a single person and $44,000 for a family of 4. Again, it doesn't designate that you are in fact impoverished. That's just, those are 138% over and above whatever those limits were. And you can see the map as to who's doing it and who's not. The next thing that's going on with this law is insurance exchanges. You've all heard about this. This is healthcare.gov. Sooner or later, they're going to get it right. What these exchanges are supposed to do is to provide a marketplace where people can shop for insurance in various levels of coverage at various premiums, and to allow insurance companies to compete within that marketplace. Remember that there were a number of insurance reforms that were enacted as the result of the Affordable Care Act. Kids can stay on their parents' policies until they're age 26. There is no lifetime limit on coverage for a particular illness. We were talking before about extracorporeal membrane oxygenation for ARDS and some of the other uses that are going on around here. It doesn't take long to get to $1 million when you're dealing with technology like that. And the insurance company previously had the right to say, we're glad you're doing better, but you have to pay for the machine from here on in because you've reached your lifetime limit. More commonly, what was happening was people would go through a serious illness, diabetes, breast cancer, cardiovascular illness, peripheral vascular disease, and over the course of years would consume enough medical care so that at some point later in their lives, they would no longer be eligible for coverage. A lot of them went into bankruptcies, a lot of them ended up on public assistance because the insurance companies would simply say, no, we're done. So that's not allowed anymore. And there are some other things as well, but this is the insurance exchanges. Washington State has one, I'm proud of you, and the rest of the states are sorting through this. Some of them have decided, hell no, we won't do it, and some of them are planning for a partnership with the government, a jointly run one. So the AMA has been fairly involved in setting up the technical details of these exchanges. Remember that in the Affordable Care Act, there's about 2,000 places where it says something in the order of the Secretary shall determine. The AMA is your voice sitting down with the Secretary saying, this is the way we would like you to determine, because these are the things that you need to consider. The legislators have no conception of any of this. But Secretary Sebelius has been very open to dialogue. And we have been pushing for direct involvement of physicians in the governance structure of the exchange. We did not want these to be something that was superimposed or imposed upon us by just the insurance industry. We also are pushing for strong networks. Some of these plans have fairly narrow networks that excludes a lot of physicians, and we are opposing that. We pushed for insurance market reforms, including a strong medical loss ratio. Medical loss ratio, for those of you who don't know it, is a mathematic way of expressing how many dollars that the insurance company takes in, it pays out. We have insurance executives making millions, if not billions of dollars. These are premium dollars that you and I or our employers pay in, and there is supposed to be some administration and some margin for the insurance company, but then they're supposed to pay out the rest of that in coverage. And what was happening was that they were finding ways to pay physicians and hospitals less and less and less and keep more and more of a margin. So now, with a few exceptions, they have to pay out 85% of the premium dollars that they pay in coverage, and if not, they have to give refunds to policyholders. It really has been AMA advocacy that won the day on the medical loss ratio. Okay, so the SGR. I'm beginning to think that some of you weren't born when this discussion started. This has been going on for a long time. In 1999, as part of something called the Contract with America that Newt Gingrich championed when he was Speaker of the House, there was some budget neutrality legislation that was passed. And they passed some crazy formula called the Sustainable Growth Rate Formula, which is neither sustainable nor growing. But what it did was it said that the expenditure on Medicare could only grow as a certain percentage of, it basically tracks gross national product. And so what happened was, and it started in 2000, was that in 2000, the government got to somewhere later in the year and said, oh my God, we don't have enough money because the SGR said that this is all we can spend, and it's September, and we're going to run out pretty soon. Okay, so what we'll do is we will take money from next year's budget, so we're not spending $2,000, we're actually spending $2,001, and we'll get through the year. Great. 2001 comes by, and now it's a little bit further back in the year, and again they're running out of money. Why are they running out of money? Well, because there are increased numbers of beneficiaries. Remember, the leading edge of the baby boom is starting to hit with this. There is increased technology. There are people living longer. There are all sorts of reasons, none of which were factored into this SGR. So in 2001, they ran out of money a little bit earlier, and by the way, they now have to start paying interest on the money that they borrowed from 2001 to use in 2000. And you could see how this works. Now we're running out of money before January 1st even starts, and we're basically at the point where we can't even make the minimum payment on the credit card. And it goes up and up and up. So the light blue line shows you what practice costs have done. And these are your costs to turn on the lights, pay your insurance, pay your staff, and pay your own salary, and your rent and all the rest of it. And the purple shows you what's been going on with the SGR. And what happens is that every year, you get to the end of the year, and we're going to start next year, and we're out of money, so we're going to have to cut fees 25%. Well, of course, it never happens. They run in with a patch. But right there is where we're going to be on January 1st if nothing is done. Okay. So the AMA has been working with Congress to try to fix this. It's all accounting. The physicians of this country do not owe the government $300 billion back. That's money that's already been spent, but it's money that hasn't been accounted for. Now, budgeting and accounting in Washington goes over 10-year cycles. So the cost of this last year was estimated to be over $300 billion. The Congressional Budget Office looked at the figures again, and there was some limited usage of things and some cost control measures that already have been going on, and they rescored the cost. So the cost right now is only $140 to $150 billion. So we're really pushing at this point to try to get Congress to fix the problem now before it grows again. Okay, so we've outlined system or principles for a new payment system, and this is a busy slide. It's just meant to show that there's a letter that we wrote to Congress, but we are working with Congress to try to make available new delivery systems, new payment systems, giving physicians an array of options, rewarding physicians for savings, particularly savings on an individual basis, so that you are not pegged to the entire class of orthopedic surgeons. If you come up with something that is novel, that does something in a more cost-efficient way, that you should be rewarded for that. And we're getting some positive news from Washington. In July, the Energy and Commerce Commission, which is one of the 3 congressional committees that have jurisdiction over Medicare, they passed out a bill that would have gotten rid of the SGR, and it was done in a bipartisan way. It had modest updates, but would have eliminated the system, this problem entirely. It's now gone to 2 other committees, Senate Finance and Ways and Means in the House, and we're working with those folks as well. It's progress, but there are concerns. There are accountable care organizations that were set up by the Affordable Care Act. There are 3 functioning in Washington State, and these are beginning to show some positive returns as well. So we're trying to turn the heat up on Washington a little bit. FixMedicareNow.org. You can access it on your smartphones, and you can, if I'm getting really boring, you can do it now, and you can send a message to your legislators and let them know what's going on. We also are spending a lot of money in Washington doing PR, and I think we bought every piece of prime advertising space in the 2 subway systems, the metro systems, that serve the Capitol. So all the staff, when they come in every day, are bombarded by these messages. It's interesting that that's the way Washington works. All right, there are still some outstanding issues in the Affordable Care Act. One of them is something called the IPAB, which is the Independent Payment Advisory Board. 15 people who get paid $140,000 a year and can have no other source of income. They can't work for anybody else. They can't be in active practice of medicine. This is their only job, and their job is at the end of the year to sit down and say, looks like Medicare is spending too much money. We therefore are going to make a cut in reimbursement across the board. Congress has very limited authority to override it, and it subjects physicians to double jeopardy because we already have spending targets under the Affordable Care Act and under the SGR. So that needs to be fixed, and we still push about medical liability reform. We believe that defensive medicine would take care of most of this $140 billion cost over 10 years, just in the amount of extra tests and defensive things that physicians are doing. So we're working on that. I'm actually a little ahead time-wise, so I'm going to tell you for just a minute how we got to the IPAB and the Affordable Care Act. And it's a little lesson in civics. This is what Andy and I were talking about before. You all know, you learned in high school that there are 2 houses of Congress, the House and the Senate. They pass legislation, which ultimately they have to reconcile, and then it goes to the president's desk for signature. What you may not know is that the internal workings are a little labyrinthian, particularly in the Senate. The Senate has very arcane rules of debate. Unless you have a 60-vote block, one person in the Senate can derail all of the business, can essentially bring the country to a halt. And at the time that the Affordable Care Act was being debated, there were 60 Democratic votes in the Senate. There were actually 58 Democrats and 2 independents, Bernie Sanders and Joe Lieberman. So they had enough votes to make sure that whatever legislation they passed would be filibuster-proof. So they passed a bill. The House passed an Affordable Care Act bill. The 2 were really not all that similar. There was no IPAB in the House bill. There were some other things in there. there was even a little bit of medical liability reform in the House bill. Normally what happens is House and Senate pass bills, they go to a joint conference committee for what's called the reconciliation process. That's where the horse trading goes on. They come out with a bill that both houses can agree on. It goes back, it's passed. Sometimes that process happens a couple of times. And ultimately, you come out with a bill that's passed, it goes to the House, and it's either signed or vetoed. One of the other things that happens in the reconciliation process is that the technical language is added, something called a severability clause, which is in almost every piece of legislation that says if any part of this legislation is held unconstitutional, the rest of the legislation stands. Now, that wasn't put in because there was no conference committee. Here's what happened. Senate passed, House passed something different, Ted Kennedy died. You don't have 60 Democratic votes anymore. A woman named Martha Coakley, who was the Attorney General, I think, in Massachusetts, ran the most politically inept campaign in the history of the world and managed to lose the safest Democratic seat to Scott Brown, a Republican. How did she do this? As soon as she won the nomination, she went on vacation for 10 days. When she came back, one of her first public appearances, she admitted to the crowd that she had no idea who Kurt Schilling was. Now, maybe in Washington you all don't know who Kurt Schilling was, but Kurt Schilling was a pitcher at that time for the Boston Red Sox. I was in the Bronx, the Boston Red Sox. I grew up around the corner from Yankee Stadium. Yeah, thank you, world champion. And Schilling pitched shortly after surgery, and his incision actually broke open during the game, and the bloody sock is in the Hall of Fame in Cooperstown. But Schilling is God in Boston, so you can't run for political office and not know that. She did. She lost. Scott Brown, who's a fairly moderate Republican, won and announced that he was not voting for this bill. So at that point, the political calculus made by Nancy Pelosi and the White House and the other Democratic leadership was, we are going to pass the Senate bill so the Senate doesn't get another crack at it. But that's why it didn't have a severability clause, and ultimately the Supreme Court had to rule on that when it was challenged, and that's why some other things survived. So it's an interesting process, and it's not exactly the way we learned it in high school in social studies. Okay, so going forward, the next thing I want to talk about is how you practice. Because it turns out that in 2001, 8% of residents wanted solo practice. Now, I realize that in this room in particular, the statistics would be very different. Most of the anesthesia folks will practice collaboratively in a group, and most of the orthopedic surgeons will practice in independent groups, and the general surgeons will find their way into various different settings. But across the board, 8% of residents wanted solo practice in 2001, and only 1% 10 years later. So people are looking at work differently. The reasons for this are lifestyle stability, work-life balance, which was a concept that was unknown when I was a resident, and I think it's much healthier to look at it this way, loan payback, and a movement towards team-based care. So the AMA is aware of this, is providing lots of tools for people to evaluate situations and to find out what works best for them. And in my House of Delegates, there is now an integrated physician practice section, which represents people who practice in those ways. All right. Graduate medical education reform. This is residency slots. Another thing that the AMA is working on. Understand that most of you in here who are House staff, your salary, by and large, is paid for by the federal government through a Medicare payment that comes to the hospital over and above what the cost of the hospital to deliver the care. The number of, does that mean it's, no, okay. The number of residency slots has not increased in 10 years. The population requiring medical care has increased. The number of medical graduates has increased in response to the projections that we will be short 25,000 doctors by the year 2025, and 50,000 doctors by the year 2039. There are more people graduating from undergraduate medical schools, but there aren't an increased number of residency slots for them to go into. The Affordable Care Act had a provision in it that allowed redistribution of unfilled slots, but that's not enough. So that if there was an unfilled physiatry residency in Washington, the funding for that could go to another residency somewhere else. I think it's in same specialty, but I'm not sure about that. So we're pushing to add primary care and general surgery among other residencies, but this is obviously an ongoing discussion about how they're going to be funded on the framework of the SGR and other budgetary issues. So we're advocating for lower interest loans. There are some tax issues regarding repayment of student loans, and we're working on your behalf in that regard. Medical students are graduating with absolutely crushing debt. The average medical student graduates with between $160,000 and $200,000 in debt from a private institution, and that affects career choices. That affects a lot of subsequent lifestyle choices. So we're working on that as well. All right, I want to shift a little bit, and I want to talk to you for a minute about prescription drugs. Again, as I said at the outset, this is something that is becoming of great interest to folks in Washington and at the state levels. The AMA is hosting webinars, which are free to all AMA members, about various aspects in these. This is not projecting all that well. There is a line here, and that line is motor vehicle deaths. And there's a white line here, which is opioid overdose. This is total accidental death by poisoning, most of which is opioid. And in 2008, those lines crossed. So more people die in this country from drug overdose, primarily opioid overdose, than they do from trauma. That reminds me, I wanted to say hi to the Harborview folks who are on remote access here. Hi guys, Harborview, when I was training, was a real mecca for trauma surgery, so I'm glad that you guys are here as well. Okay, so this is an epidemic, a tremendous problem in this country. And this is a very busy slide, but what I want to point out to you is this. In the left-hand circle, just look at blue. Blue is, this overall thing is where people are getting the drugs that they are using for non-prescription purposes. And over 50% of them are getting them free from a friend or a relative. These are people who are using these drugs either to control their own pain, but more often than not to treat depression, for which it's not indicated, mood altering, all sorts of things. So the blue in that left-hand circle is better than 50% of the diverted drugs come from a friend or a relative for free. This is not a street drug problem. And in the circle on the right, the big orangey, pinky Pac-Man thing, that's 81% of these drugs come from a single physician. So what's happening when you go back and look at how this problem occurs, usually after an overdose, you find that more often than not, they got it from a friend or a relative, or they stole it from their grandparents' medicine cabinet or their parents' medicine cabinet, in the case of kids. And most of these drugs are prescribed by one doctor. So, and you've all seen this guy in the emergency room. You are not controlling my pain. For those of you who work in ERs or deal with people like this, our evaluation and our reimbursement sometimes, and perhaps even our continued employment, depending on what situation we're in, can depend upon how this guy fills out his post-encounter questionnaire. Here's a statistic that I ran across, and it just bowled me over. If a patient takes hydrocodone 4 times a day for 90 days, regardless of the diagnosis, doesn't matter, across the board, there's this 2/3 chance that they'll be taking it 5 years later. I can tell you that I see this all the time in my practice in a community where people come in for carpal tunnel, trapezius metacarpal arthritis, and they're taking Percocets, they're taking Vicodin on an ongoing basis. And I have to have a discussion with them about how I'm going to control their pain and explain to them that, you're sort of a drug addict. And we have to talk about this on a number of levels. So it's a problem, and we're the ones who are causing it because we're the ones who are writing prescriptions. So think about this the next time you write a prescription. Does somebody need 30 Tylenol with codeine after a carpal tunnel? I went down to 12. Do people need 100 or 200 hydrocodones, Percocets, whatever, after some of the orthopedic procedures? There are other ways to take care of this, and just to be aware that it is a problem. So we're collaborating with organized medicine. We're advocating, we're doing all of the things that we do on a number of issues. But this is a problem that we as physicians need to take ownership of in each of our practices. And this is also the single most important reason that you need to be an AMA member, because none of your particular societies, remember I belong to 5 of them, none of my particular societies can be the one who can stand up to Congress and say, this is a bad piece of legislation because this is how it's going to affect all doctors. And this is something that again, there's great interest in. It's going to affect our practices. And it is an advocacy issue for the AMA. All right, so for the last few minutes before we get to questions, I want to talk about the AMA strategic plan and what we're doing in response to an overburdened system and problems that physicians are having lower levels of satisfaction and unpredictable income, increased workload. Again, you can read the slide or you can talk to some of your attendings, or for those of you who are attendings. These are the various frustrations that a lot of us face. So we did a couple of studies in conjunction with the RAND Corporation, and one of the things that we found out was that physicians who are by and large satisfied with what they do have better performance on quality metrics. Not only the quality metrics that the government uses, but when you look at patient satisfaction, if you have a happy doctor you're more likely to have a pleasant encounter, and if you have a pleasant encounter and you don't spend a lot of time bitching about the world, but you get to work on the hemoglobin A1C and your blood pressure and the rest of it, that people actually tend to do better. We did the study with RAND. It was just released. It's a big 130-page book that interviewed doctors in all sorts of different practice settings, from onesies, twosies, orthopedic surgeons, general surgeons, primary care physicians. Sorry, I got ahead of myself. We found that physicians are most satisfied when they find themselves in a position that they can deliver quality care with minimal regulatory burdens or hurdles. So we are looking to provide best practice scenarios for all of these different practice settings, for large groups, although the large groups tend to find their way on their own, but for people who are in small group practices or loosely affiliated networks, how they can navigate their way through this system in order to provide the opportunity for patient and physician satisfaction. The second area of our strategic plan is improving health outcomes. For that, we chose diabetes and cardiovascular disease, not to reinvent the wheel, but to try to look at how these things can be approached on a community-wide and population-wide basis. This is more than just controlling the A1C to a certain level. This is more than just giving a beta blocker after a heart attack. And these are the 2 biggest dollar figures in the U.S. health budget. We spend $500 billion a year taking care of diabetes and cardiovascular disease. So what we're doing is we've partnered with the YMCA that has a really good program for people who are identified as pre-diabetic or at risk for diabetes. It includes lifestyle counseling, weight loss, physical activity, dietary counseling. We're working with the Y and with stakeholders like AAFP, American College of Physicians, American College of Pediatrics, to find a way to integrate this program into the whole practice module. And we're starting it in Delaware, Indianapolis, and Minneapolis. For cardiovascular disease, we're doing a pilot study with a group called the John Armstrong Institute in Baltimore, which is affiliated with Johns Hopkins, but it's basically a community health plan-based system to see how we can use community resources. Passed the first round. Don't blame me, I wasn't on the committee. We were going to give a grant for 10 schools, $1 million each. So out of the schools that responded, 30 were chosen to go to the next level, and they were so good that we actually ponied up another $1 million for the 11th one, and they are coming up with all sorts of innovative ways for medical education, which will then be publicized and transmitted through the community. So the strategic plan, we think, is going to increase quality, give us better patients, better doctors, and better medical students. So with that, I would encourage you to ask whatever questions you have. I thank you for your attention. Please join up. We need you. Thanks. And that's my email address for anybody that wants to talk later.
So thank you for covering just about everything in medicine. There are a few things that have been left out. This is a large audience and obviously a very expansive topic. Are there any immediate questions or responses to Dr. Gurman? Let me hit you with two things then. So I'll do a little audience poll. So three major problems in terms of modern medicine, one being a too volumetrically based practice, one being tort reform, and one being increasing bureaucracy overwhelming our daily practices. Let me just poll the audience what they think is the main problem. So only one show of hand. What is your main perception of problem of medicine as you're doing it? Is it being overwhelmed by bureaucracy and metrics? Show of hands, please. Good, thank you. Or lack thereof. Show. Is it a bird?
Payment paradigm, and it brings with it all the attendant stuff. It doesn't allow, for example, payment for episode of care. With episode of care, a lot of bureaucracy goes away. We're going to pay you X number of dollars for a total hip, and you do with it what you will. We're going to hold you to some quality metrics down the road, but we don't care if you fill out surveys or meet intermediate benchmarks, because now it's your money at risk. So that the care organizations are getting for that a little bit. The AMA has had limited success in getting everybody to use the same billing form. The 1500 billing form before we went electronic was a huge problem. I used to, when I was with a large group, we had 27 insurers, and I think we had 25 different forms that we had to use. So we were able to get it down to one form that everybody would agree on. It's an ongoing problem. We understand it. We're pushing at it all the time. We're talking to bureaucrats, and their raison d'etre is to make more bureaucracy. So it's hard, but yes, it's something that we work on all the time.
Any other questions? If not, I may ask a question.
Sure.
We love life as a period where we spend more and more dollars on healthcare. How is the AMA thinking about that period of life, and how we can be smarter in applying appropriate steps at that junction?
Yeah, it's a very touchy issue, very difficult issue for political reasons. With the backlash about the ACA publicizing death panels, which was really a reprehensible political tactic, people are very skittish about that. The fact is that we spend something like 80 to 90% of Medicare resources on 10% of the Medicare beneficiary population, and the overwhelming majority of that is at end of life. So the AMA is leading through its Council on Ethics and Judicial Affairs discussions with ethicists, with community stakeholders about how we approach end-of-life issues. That's a national discussion that has to be had, and it is a very, very difficult one to have. If I'm fortunate enough to be president of the AMA, that actually is what I'm about as my theme for the year, to try to get people to come about that. I actually, since there are no more questions, I have 1 or 2 more minutes, so let me make a commercial for political advocacy and political activism. Every one of you should, wherever you end up, or if you're here, should do it here, should start developing relationships with your legislators. Because at some point in your career, you're going to need to see a legislator and say, this is a problem for me, and I need to talk to you about why it's a problem for me, why it's a problem for my patients, and why you need to understand what's going on. You can't show up once a year wearing a white coat and some rally day and have anybody pay significant attention to you. So for those of you who are in training, wherever you end up, what you need to do early on is go into your county, state, as well as federal legislators, sit down and say, my name is Andy Gurman. I just moved to Altoona, Pennsylvania, where I didn't grow up. I'm planning to live here for the next 30 years or so. And I just wanted to introduce myself. I don't have anything in particular to ask you about. But now you have to go with the name. And then when they have a fundraiser, you go or you send a check for $25 or $50 or $100, whatever it is. And over the course of years, you develop a relationship with these people. You see them in the supermarket. Your kids may go to school together. So that when it does become time for you to really engage, when that one issue that truly gets your dander up, you are so incredibly effective to do it that way. All of politics is relationships. We as physicians are not trained that way, particularly in the surgical specialties or in the OR. You know, it happens. If I say fix the autoclave, they fix the autoclave because it's my OR and they got to do it. When I tell Congress to fix this, they don't necessarily do it. There was a question, blue shirt, bow tie.
Yeah, I was interested in the innovations the AMA is supporting with those 11 projects, but what specific outcomes are being measured to ensure that those projects are relevant to us clinicians as in what we want to see our future in medical practice?
Well, what's happening is that the grants are each for $1 million, but they are over a 5-year period. So every year, the groups have to come back and report to us about what they're doing and whether they're going forward. The tie-in to clinicians at this point is speculative. And one of the groups, one of the medical schools, has decided that they're going to take some students and they are going to teach them by assigning them a patient the first day they get to medical school, 1 patient, 2 patients, whatever, and the students are going to learn about cardiovascular disease by following a patient who has cardiovascular disease. You're going to have to understand cardiac physiology to understand how the digitalis works. Not bad for an orthopedic surgeon, huh? You're going to have to learn renal physiology to find out why your has to be limited because of creatinine clearance. So they're looking at a completely different way rather than putting your tush in a classroom seat for 2 years and have you learn all this stuff and then turn of information that kids aren't practicing medicine that way anymore. So and there are 11 of these different things. They all come together twice a year to cross-fertilize, and at the end of 4 or 5 years, we hope to have something that we can share with the rest of the world. Oh boy.
Oh yeah.
That struck a nerve.
Back there, back right. And tell us who you are, so just so we as a community get to know one another.
So my name is Mike Dilbert. I'm one of the GME defendants here. The question I ask specifically is I'm very concerned about the cost that medical students and residents face in terms of acquiring their between the goals of creating more primary care physicians, but at the same time creating a body of academic physicians who can train the next generation of doctors. It's certainly true that residents who seek fellowship training with a goal toward participating in academic medicine will actually pay more for their fellowship training by deferring income for 1, 2, 3 years than they might actually pay for their entire education to date. And I'm wondering what the AMA's idea is in terms of reconciling that tension between creating more primary care physicians and also creating more specialty trained physicians, fellowship trained physicians who can then work in academic centers where
It's a really excellent fellowship. So that's an interesting. Advocating for forgiveness of financial ways, tax deductibility of interest, to try to get that better. But let me throw. It's not one of these 11 grants, but which is something that we've talked about. Somewhere in the United States is the best histology lecturer of any medical school. Right? So why doesn't that person teach histology to all of us? Right? With webinars, with remote learning, and more importantly, why doesn't that person teach it in the summer before our students? look at that, various things that we do, and you look at time management through the 4-year block of medical education, alternatively, on a cardiac, some kids may be able to nail it in 1 or 2, particularly if they have access to online learning tools. Some kids may need to do more. So one of the innovative programs is to look at metric-based progression rather than chronologically based progression. So there are a lot of innovations that come out of this. Look, if you make medical school 3 years rather than 4, you're taking 160 to 200 and turning it into, I don't know, 100 to 150. That in and of itself is profound.
Well, now we're breaking loose. We have to probably questions. So, the semi-politician in the front here, Dr. Dunbar, maybe.
Peter Dunbar, an anesthesiologist professor. There's a lot of pressure from federal agencies to increase the scope of practice of nurses and PAs, and primarily to produce more primary care providers. At the very same time, we're hearing that there's an anticipated shortage of physicians. It would seem to me that it would be natural for policymakers to persuade a substitution of nurse practitioners for physicians to solve this problem. What's the AMA's take on this?
Also a good question, one that I hear not infrequently running around. So the AMA policy is very clear, and that is that people should practice within the scope of their licensure. It is also the AMA position that nurse practitioners should practice in a collaborative agreement with a physician. Now, there are many states where that's not the case. And as you certainly know with the CRNA scope of practice issue, there are places where they're pushing hard for independent practice. I think that you're right. I think that people are going to look at nurse practitioners and to a lesser extent PAs as answers to the access problem. And certainly with the Affordable Care Act and 1 million people online very soon, there's going to be a tremendous staffing issue. We are ultimately going to practice in teams, and the AMA's position is that the team needs to be led by a physician. But the reality is that not every patient encounter is going to be done directly by a physician, hopefully under supervision in one form or another. It's interesting when you look at some of the arguments that were made by the advanced practice nurses that they would fulfill the needs in underserved areas. And we have a map in Florida that shows where the docs are, shows where the voids are, and then you superimpose the nurse practitioners, and they're exactly where the docs are. Because they also have kids that they want to have go to decent schools. They also want to be able to go to the movies or eat at a decent restaurant. I mean, you know, so there are lots of arguments to be made. There are scope of practice issues to be fought every day. We just sent a letter to the Secretary of the VA because the VA was considering adopting a policy that all advanced practice nurses would practice independently. So, you know, yeah, good question. We're advocating every day on behalf of physicians. And the other thing you guys may not know, lots of therapists are now graduating as a doctor of physical therapy, and advanced practice nurses are graduating with a doctorate of nursing degree. So the AMA has been very, very clear, and it's in the Affordable Care Act, that people have to clearly state what their credentials are. So that when somebody's lying in a hospital bed and somebody comes in and says, I'm Dr. So-and-so, that it's not Dr. Nurse so-and-so, it's not Dr. Physical Therapist so-and-so, that it's Dr. Andy Gurman who went to medical school. But I'm staying here.
Gurman has some more time, but we're very happy as a proceduralist.
Thank you all for coming today.